Welcome to the No Health, No Justice podcast on health rights for people who use drugs, featuring the Legal Action Center and our attorneys who work on these issues. Legal Action Center is a law and policy organization that fights for the rights of people who use drugs, people living with HIV, and people with arrest and conviction records. LAC provides direct legal services and engages in litigation to ensure access to care, fight discrimination, and protect the privacy rights of people who use and have a history of using drugs. We welcome our featured speakers, Rebecca Joa, Diane Johnston, Jackie Seitz, Amber Black, and Alexandra Warren. And this session will be facilitated by Senior Staff Attorney Deborah Weed. Take it away, Deborah.
Hi, everyone. Can each of you tell our audience your title and your scope of work at LAC?
Sure, I'll start. Hi, everyone. My name is Amber Black. I work at LAC as a staff attorney for health privacy, mainly providing technical assistance and training to providers and individuals around the nation who may have questions about how to comply with health privacy laws like HIPAA and the set of law and regulations that we refer to as Part 2, which governs the confidentiality of substance use disorder treatment records.
Hello, I'm Rebecca Jobe. I'm a senior staff attorney, and I work on litigation and legal services for people who use drugs, primarily through the enforcement of anti-discrimination laws like the Americans with Disabilities Act and the Rehabilitation Act.
Hi, Diane Johnston. I'm also a senior staff attorney here at LAC, focused on litigation, really in the same areas as Rebecca. So excited to have this conversation.
Hi, my name's Jackie. I'm a senior staff attorney for health privacy. I work closely with Amber on enforcing and advancing the privacy rights of people who use drugs and people in treatment and people living with HIV.
Hi, I'm Alexandra Warren, and I'm a staff attorney with the Community Health Access to Addiction and Mental Health Care Project, also called CHAMP. And it's a ombudsman project in New York State, which helps people overcome barriers to substance use disorder and mental health care.
Well, thank you all. Now, let me ask you, why is the focus on drug user health and rights important?
There's a long history of disparate treatment of people who use drugs depending on what their race is, their social and economic status. So these disparities result in punitive outcomes, mainly for Black people, Latinx people, for poor people. People are, don't have access to jobs, to housing. They're put in jails and prisons because of drug use and because of who they are and what drugs they use. And so this happens in all areas of life, but LAC right now is focused on addressing disparities in stigma in healthcare, where drugs, race, and class combine to create what can feel like an insurmountable barrier to healthcare, which all people should have open access to. And I think that there's an irony in the fact that as the national discourse is shifting to calling for a health approach to drug use, when people who use drugs try and access healthcare, they are openly denied that healthcare because of their drug use. And so our healthcare system continues to treat the serious healthcare needs of people who use drugs as the result of moral failings. And so although addiction functions like any other health condition, as a combination of genetics, environment, and behavior, it's treated differently, and it's thought of as something other than a health condition. Instead, it's thought of as only a bad choice that's the fault of an individual deserving to be policed rather than treated. And so ensuring access to equitable healthcare is an important part of interrupting our country's structures of racism and classism, but we're trying to ensure that people receive equitable healthcare and the healthcare that they want. That's super important. Not only should it be equitable, but people should be listened to. They should be believed when they're trying to receive healthcare. And we see so often that people who have used drugs just openly, health providers choose not to believe them or have a very paternalistic attitude and think that they can't make decisions about their healthcare. But we're trying to address all of those things by enforcing rights that prohibit discrimination or require privacy of health information, and also that work towards equitable healthcare coverage.
Rebecca, I love the way that you put that. we all deserve quality and respectful healthcare, even if we're using drugs. The disparate treatment between the different types of drug use and people who use drugs differently, as you said, it's just amplifying the systemic racism. It's amplifying the segregation in our healthcare system. And so many times suspected drug use is the reason or the excuse to provide worse care to Black or Brown patients or poor patients. So I think that Legal Action Center putting the rights of people who use drugs front and center is an important component of addressing the whole racist system of our healthcare, you know, not to put it too grandly, but I really do think that it's an important component.
Let me ask another question. We know that people that reach out to our organization at Legal Action Center for assistance are facing high levels of various types of stigma, discrimination, and other lack of meaningful access to healthcare and other life needs like housing. Can you provide some examples of the kind of cases that you're working on?
You know, there's multiple of us who work on a certain law, but we are enforcing different laws and different types of protections. And so one of those is anti-discrimination protections. And I'll just say a teeny tiny bit about the law. So these laws, like the Americans with Disabilities Act and the Rehabilitation Act, and there's some state laws, but they protect people with disabilities, and substance use disorder is a disability. And so people can't be treated differently on the basis of their substance use disorder. To be in the definition of someone that has a disability, you technically have to no longer be using drugs illegally, but you can't be denied healthcare. And so that is something that we're really trying to work on enforcing, because that second part of it, where you can't be denied healthcare because of drug use, is something that hasn't been enforced yet. But essentially, with our anti-discrimination cases, what we see is that people who are no longer using or currently using are denied healthcare. For example, we see a lot of denials when people are trying to access nursing homes. They are denied because they're taking a medication for opioid use disorder. That's a very common type of discrimination, and it's fairly easy to spot because it's known that the person is taking medication for opioid use disorder. And so there's open discrimination against methadone and buprenorphine. Other types of discrimination that we're seeing are, you know, people who otherwise could receive certain types of care in their home, which might not sound like a big deal, but it kind of is. It's much better to receive care at home in a less restrictive setting, and in just the comfort of your own home, than it is to go to an outpatient clinic every day or to have to stay in an inpatient rehab for the course of treatment that you need. But they're often denied care from a, you know, home care agency because of their past or current drug use.
So I would just add, you know, we're seeing this kind of discrimination across the entire spectrum of healthcare services and the needs of people who are currently using drugs or are former drug users and are now in recovery. You know, medication for opioid use disorder really is the gold standard in treatment. And so you have people who are being denied that kind of evidence-based care when they're seeking other types of services, whether they're seeking to address their substance use disorder or other healthcare needs. And they're really having to choose between using that evidence-based medication and having other significant, important needs met. And one, you know, just to mention one other issue related to MOUD is even the ability to access it in the first instance is a huge hurdle. And we know that access is lower in Black and Brown communities, in lower income communities, whether it's, you know, a lack of providers in certain areas or pharmacies saying that they don't want to serve this population. So, you know, we're also really focused on how to ensure that people have access to these medications in the first instance.
Now, let me turn to our privacy experts here, Jackie and Amber. Can you just tell us how all of this conversation about stigma and discrimination relate to individuals' privacy rights?
I think what comes to mind in the first instance is when people are receiving treatment for substance use disorder in the form of medication for opioid use disorder, and this information is shared with another provider. So say, for example, someone is receiving treatment in a clinic and the clinic then shares that information without the patient's consent and not pursuant to an exception in the law with the wider hospital system, we'll see sometimes patients complaining of discriminatory experiences that they're having with other providers or specialists who are now privy to that information that the patient didn't necessarily want to share. Mind you, there's always opportunity for a patient to share that information on their own with another provider if they'd like to, and or to consent for their initial provider to share that information, or even in an emergency, like a bona fide medical emergency, for the initial provider to share that information without the patient's consent in the limited circumstance. So people often say, oh, there would be no way for another doctor to know in case of emergency, and that's important information. Well, that's not necessarily true. And so we find that it's especially important to protect those rights. And we also see sometimes devastating consequences outside of the healthcare system. So that information is shared in civil circumstances. Someone can get embroiled in the family regulation or child protective system if that information becomes, again, available to people in that realm, or sometimes in the criminal legal system. If that information is shared, people can face devastating consequences there as well. So again, it's just of the utmost importance that we protect people's privacy rights when we can.
Let me ask Alexandra, can you just give us some more details on how insurance discrimination impacts people who use drugs?
So the complexity of insurance is a barrier to care regardless of who you are. But then when you couple that with being in crisis or having an emergency medical condition, it's absolutely insurmountable. And in addition to that, many medical providers don't know the insurance access that their own patients could benefit from. So patient financial services in medical spaces will not often know how to advocate for their patients. And on top of that, there are providers who stigmatize against people who use drugs and will give false information, which obviously stems from a lack of empathy or recognition of substance use disorder as a health issue. So when you are at the point of service, when you are at the point of care, any questions or confusion you do have should be answered by those spaces, and they often aren't. And then people will leave emergency medical spaces or leave treatment facilities and be faced with medical debt that they didn't even know that they were getting into or know how to handle going forward. That's why projects like CHAMP are so important, because it's not only overcoming the specific barriers that people face, but also empowering community members with that knowledge, because if you have the knowledge, you can advocate for yourself or other community members or family members and loved ones when they're experiencing the confusion that so often happens. Insurance barriers are they just create such a level of administrative burden that should not be happening when somebody's going through a crisis or something that they need support in.
Can I add a quick kind of like case example that I think shows some of how all of this intersects? We had someone contact us who was in a hospital, essentially dying from cancer, and they needed care in a skilled nursing facility. And so they're in the hospital for some time. They asked for access to methadone because they're prescribed methadone for their opioid use disorder and have been taking it for about 30 years. And so when the hospital approves the person for discharge, they change, whatever order, they change in their medical record the level of care that the person needs. So now that person doesn't need hospital care anymore. They need skilled nursing facility level care. So insurance isn't going to cover hospital level care anymore. So they try and place that person in a skilled nursing facility and send over their whole medical record. The skilled nursing facility sees, oh, this person takes methadone, and over, these referrals go out to like 200 or 300 skilled nursing facilities at a time. Everyone comes back and says, we don't accept patients taking methadone. So now this person is stuck in the hospital. His insurance is no longer paying for his hospital care because he was approved for a lower level of care. No skilled nursing facility will accept him. Instead, what ends up happening is the hospital decides to taper his dose of methadone down very rapidly so that they can get him into a skilled nursing facility because they are no longer being paid for his care and don't want him there. And so he was forcibly removed from methadone, went into like horrible withdrawal because it was tapered too fast. And it's just like, there's so many parts of this system where that shouldn't have happened. The skilled nursing facility is discriminating. The hospital is basically aiding and abetting that discrimination by stopping standard of care treatment to try and comply with these discriminatory requirements. And his insurance has just kind of like failed and is like, okay, well, you were approved, so we're not covering it, which I'm not saying is illegal, but I just think kind of shows the problems and the complexity that people go through. And he basically died in agony for no reason. So that's just an example of how all these things intersect, and also the real pain that it causes people when they're going through health crises, to have to deal with like all of these forms of mistreatment.
To our next question, LAC's No Health Equals No Justice campaign is an initiative to work on achieving greater racial equity at the intersection of healthcare and criminal legal reform. Basically, we don't want people being criminalized for conditions related to their health. Can you all tell us a little bit more about the broader impact that LAC's drug user health and rights work is seeking to achieve?
Talking about how we can't decouple what's happening around drugs in this country from racism. And so in our work, we're trying to make sure that people have access to care, and racism is so pervasive that it's evident in anything that you try and do. And so of course we're going to see health disparities worse for people of color because they're facing racism at every step of the way. And also there's a moralizing of drug use. I mean, I was presenting somewhere and someone asked about what are the moral consequences of drug use? And I was like, what do you mean the moral consequences of drug use? It shouldn't be tied to morality. And I think, as all things in this country, the people who get the brunt of that are Black people. And so addressing discrimination towards drug use is critical to addressing racist structures. There's inaccess to treatment, there's limited access to treatment, there's discriminatory access to treatment, doctors maybe only want to work in certain communities. Those sorts of problems are real. We just choose to blame certain people for using drugs instead of saying, you know what, it doesn't really matter why someone started doing something. Like for any health condition, like smoking has an increased chance of leading to lung cancer. We don't say we're not treating your disorder because there was some sort of, behavioral component in that. But it happens with drug use, and it's so tied to racism in a way that's, I think, is actually really hard to point out, because it's hard for the individual to know what's a legitimate healthcare decision. People are, thrown into this system and they're told, this is how it works. You can't get into a skilled nursing facility because you're taking methadone. You can't get this surgery because you're using drugs. And it takes so much energy to try and figure out what should be happening, and then even more energy to try and overcome what is racist and what might not be believed as being racist. So anyway, that's kind of just my explanation of what we're trying to do on a larger scale, and just trying to show that so many of the reasons that people are actually denied healthcare are not legitimate, are instead based in racism and stigma towards drug use, and empower people to advocate for their rights to treatment and for the right to decide what treatment they want, for their right to keep their information private.
From the privacy perspective, where I see the intersection with what Rebecca just talked about is that our health records are supposed to be this, they're supposed to help us stay healthy and help our providers take care of us, but they're also increasingly legal documents and insurance documents that insurance uses to decide if the person deserves this level of care or that level of care. Society's capacity for collecting and processing large amounts of data has totally outpaced any sort of concern for individual privacy rights or any recognition of the very real harms that people face when this information that's been collected and collated for financial, legal, insurance, and health reasons just gets flooded out endlessly and used basically as a rap sheet and a way to discriminate against them in the future. Our health records are no longer just our health records. They're also this whole other monster. And so trying to identify someone's individual right to say, this is the information I feel comfortable sharing with this treatment provider, and if they need more information, they can explain to me why they need that information. I think that is something that is achievable and something that we can be working towards.
Well, how can people listening to this podcast learn more about the work that you all do?
Well, you can always start at our website, lac.org. And you can also give us a call at 212-243-1313. And we'll make sure you get in contact with the right person.
In addition to those resources, if you or somebody that you know had any difficulty accessing mental health or substance use disorder care, my project CHAMP does have a general helpline. The number is 888-614-5400. And consumers, providers, advocates, anybody can call. Any range of insurance is accepted, any language access is accepted, any immigration status is accepted. So yeah, you can call the CHAMP helpline and see if you can receive any help overcoming those barriers.
On our website, we have a legal help for people who use drugs page where individuals or providers or lawyers, anyone really, can fill out an intake or get more information about legal, protections and for people who use drugs. And we have 3 areas. One is access to MOUD, one is access to healthcare for drug users, and one is emergency care when people present with an overdose.
This is been an amazing conversation, and it is one that is sure to stimulate a lot of other conversation. But we are at Legal Action Center are just so proud of our team of advocates who are here fighting discrimination, fighting stigma, and fighting for the rights of people to have whole and healthy lives and to have their dignity and humanity respected. And so again, to get in touch with Legal Action Center and be connected to any of these resources, the main number is 212-243-1313 or info@lac.org. Deep thanks to my colleagues, Rebecca, Diane, Alex, Amber, and Jackie and Debbie. And thank you again.